Hola, muy buenas noches. Bienvenidos al curso de Ingeniería Clínica 2.0. Mi nombre es Luis Fernández y el día de hoy nos acompaña, ahora sí que invitados especiales de Canadá, de Ontario, el ingeniero y muy buen amigo Bill Gentles, que nos va a hablar acerca de un tema muy importante en la sesión número 14 de este curso. La sesión es titulada Raising Your Clinical Engineering Profile with Relevant Metrics, que prácticamente se resume en cómo aumentar el perfil de los ingenieros clínicos basados en métricos relevantes. Entonces, sin mayor preámbulo, le voy a dar la palabra a Bill Chentos para que pueda él hablarnos un poquito acerca de quién es, qué es lo que hace, un poquito acerca de también su trayectoria y pues bueno, para entrar en materia. Entonces, voy a cambiar el idioma a inglés a partir de este momento y espero que puedan disfrutar de la sesión, al igual que muchísimos de nosotros ya lo hicimos. Okay, so Bill, welcome. We are very happy to have you here with us tonight. You're a very busy guy, so we appreciate that you're here with us and to talk about this really, really important topic, raising your clinical engineering profile with relevant metrics. We've talked about a couple of sessions on the phone on how clinical engineers in Latin America struggle to prove themselves regarding their efforts and the working, and especially to just convince directors and managers about how important the job that they're doing is and how does their job just helps out in any way they can in the hospital. So without further ado, welcome to our 14th session of the Clinical Engineering 2.0 course, and we'll take it away. I'll leave it to you.
Thank you, Luis. It's a great pleasure to be here, and I'm really happy to have been invited by Luis to give this webinar, and I hope we can all learn something from this. I'm hoping to learn something from you people as well. So I'm going to be encouraging and asking you questions as I proceed, but let me first start by just introducing myself a bit, giving you some idea of where I come from, what my background is. So I hope you can all see the screen. I'm going to flip through some slides fairly quickly here. So I worked for 28 years as a director of biomedical engineering at a large teaching hospital in Toronto called Sunnybrook Hospital. It's affiliated with the University of Toronto Medical School. It's a large tertiary quaternary care hospital with a trauma unit, open heart surgery, orthopedics, a burn unit, many of the typical services of a large teaching hospital. I worked there for 28 years and got a little in need of a change. So I left there, I took early retirement. I left there and started working as a consultant for Canadian hospitals, a freelance independent consultant. And I've been doing that for the past 18 years. So the work included equipment planning, accident investigations, and service improvements in clinical engineering departments across Canada. I've also done some consulting work in foreign countries, specifically Malaysia and Mongolia. I had a 3-year contract recently in Mongolia. I traveled there twice a year over a period of 3 years, helping them develop a new blood service facility and specifying and helping order $25 million worth of new equipment for this facility. I've been growing more passionate about doing volunteer work as I get older, and I'm getting more interested in working with low resource countries. So I've done participated in workshops organized by the American College of Clinical Engineering. That's where I met my friend Tom Judd. But I've participated in workshops in Ecuador, Chile, Nicaragua, as well as Kosovo and Ghana. And I also do a lot of volunteer work for the Canadian Medical and Biological Engineering Society. I'm chair of their International Outreach Committee. As part of the work in that committee, I initiated a crowdsourcing campaign to fund the Tools for Text grant, which we're using to help biomeds in low-resource countries buy much-needed tools. And those of you who, I encourage you to take a look at our website. There's an application form there, a list of countries that are eligible to apply for the grants, and a very simple application process, which I encourage you to investigate and perhaps submit an application for. And you can write to me directly if you want more information. So that's enough about me. That's my introduction, but I'd like to ask some of the participants, perhaps you give me a bit of feedback as to which countries you're working in, and are you working, what kind of a health organization are you working in? So could people please put up some words in the chat window? Just tell me what country you're working in. Give me a sense of who's out there. That would help me understand who I'm talking to, because I can't see you guys, and I'd really like to know a bit more about you. So,
okay. So Bill, I'm going to translate a little bit so that people can also write in Spanish, and I could surely, I could also translate the question. So, para nuestros asistentes, el señor Bill por acá pregunta si pueden ustedes escribirnos de dónde están uniéndose con nosotros y también qué es lo que están haciendo en su organización de salud, si es una empresa o si es una institución de salud. Tal vez 2 o 3 personas quisieran escribirnos por ahí en el chat, o bien si quisieran también tomar el micrófono en inglés y comentarlo, excelente. All right, so Bill, I'm gonna start reading some stuff. All right, so
super.
Angeles Jaime is joining us from Mexico. Jorge Takenaga is joining us. He says, my name is Jorge Takenaga and work as a biomedical engineering professor at a private university in Monterrey, Mexico, which is the university that I studied. Good evening from Nuevo León, Mexico. I manage colleges, dental school clinics. All right, so mainly a professor, also a clinical engineering manager from a dental clinic. Also here, Carlos Alarcón from Chihuahua works as a biomedical engineering at a private hospital, Star Medica, which is a 14 hospital chain in Mexico, one of the biggest ones. Frida Cáceres, hi, I'm from Mexico. I work as a biomedical engineering professional in private hospitals as an outsourced provider. Sofia Alvarez, you want to speak up? I see you have the microphone open. I think not, so I'm just going to silence it. All right. So Diana Infante says, good afternoon. I currently work in private hospital in Mexico as a biomedical engineer. So as you can see, like most of the people are joining from Mexico, and mainly they are clinical engineers working in a healthcare facility, as well as Jorge Takenaga, which is a professor. So yeah, I mean, that's
Great.
All right, great.
Okay, thank you. That gives me a bit of an idea. And I'll be asking for more feedback from participants as we go through this. But first, let me just give you a brief outline of what I'm going to be talking about before I jump into it. I think somebody needs to mute their microphone. Okay. I'm going to talk about some basic quality concepts. What is a metric? I'm going to talk about what metrics do senior administrators look at. If you can understand what your senior administrators are measuring, then you can perhaps have some influence on them. I'm also going to talk about the clinical engineering standards of practice for Canada and the peer review process. This is one tool that we use to raise our profile in the senior administration levels of our hospitals. I'll talk about ways to understand customer stakeholder needs, and I'll talk about developing metrics from customer feedback using the PDSA Rapid Improvement Cycle, and also using data from your CMMS. And then finally, we'll get into some question and answer session where you can ask some questions and I'll try and answer them. And maybe Luis can help me with those. Okay, let's jump into it. So basic quality concepts. What is quality? Quality is, or a quality service is a service that excels at meeting customer and stakeholder needs. So the key issue to identify here is, what are the needs of your customers and what are the needs of your stakeholders? So first question, I want some feedback from the participants. Who are your customers? Can you tell me, if you're working in a hospital, who do you think your customers are? Can somebody type something into the chat window, or Luis?
Sure. So Bill lo que está preguntando ahora es quiénes son los clientes de una persona que está trabajando en un hospital como ingeniero clínico. Carlos Alarcón says patients. Diana Infante, the patients and the hospital management. David Cano says patients. Michelle, patients and doctors. Ilse, doctors. Carlos Alarcón, doctors. Enrique Poncio, managers for the dental clinics, whom I report services to, nurses, doctors, etc. All right, great.
Great. Okay, thank you. Appreciate that. It's interesting that in my hospital, the first answer I would have given would be nurses. The nurses are the people who are mostly hands-on with the equipment. That may not always be the case. It may be the doctors who are the stakeholders. I'd be interested in Canada, we do not have much direct interaction with patients. So we do not consider the patients our customers. Rather, the people who are delivering care to the patients are our customers. However, the patients would be maybe an example of a stakeholder. But again, a question for people. Can you think about it in a slightly different way? Who are your stakeholders? These are people you don't deliver service directly to, but who are impacted or are worried about whether you're delivering a good service.
Ok, ahora la pregunta es, ¿quiénes son los stakeholders? ¿Quiénes son las personas a los que les afecta de manera positiva o negativa los resultados de un proyecto u operación con el Departamento de Ingeniería Clínica? ¿Quiénes son los más interesados? ¿Quiénes son los afectados? ¿Quiénes son los beneficiados? All right, so we're gonna just ask who are the people that get benefited or impacted either by a project or an operation regarding clinical engineering. So on your perspective, Bill, what is the, and keeping this a little short just to give people here some time, what is the difference between customer and stakeholder? Can
Sure.
a customer be a stakeholder as well?
Yes, although it is a slightly different concept. Customers are people you deliver direct service to. So a doctor or a nurse calls up and says, my infusion pump is broken. I need you up here right away to get it working. They are your customer. You're delivering your service to them directly. The person you report to in administration, your director, if you're not doing a good job, it makes him look bad. So he's a stakeholder in you providing service, but you don't provide service to him directly. He just is concerned if you're not providing good service. Similarly, the CEO, as someone has said, the CEO or the chief medical officer is a stakeholder in that your service may make them look bad if you're not delivering your service well.
Okay. Great.
So CEO is a key stakeholder.
Yeah, CEO, we have David Cano here, CEO, CMO, Enrique, patients, teachers, students, the dean of the dental school, and the vice chair for health sciences as well. All right, great.
Great. Yeah. Those are all great examples of stakeholders. Thank you. Thank you, people. So then the next question, if you're trying to deliver a quality service to your customers or your stakeholders, how do you know what their needs are? How do you know how you're going to be able to meet their needs unless you know what their needs are? So that's question number one in a quality improvement exercise. You've got to understand customer and stakeholder needs. And then the next question is, how will you know how well you're meeting their needs? What are you going to do to find out how well you're meeting your customers' needs.
Ok, entonces ahora la pregunta es, ¿cómo saber qué tan bien estamos llegando a las expectativas de las necesidades de tanto los stakeholders como los clientes? Y también cómo sabemos cuáles son las necesidades que tienen ellos. Esto lo pueden ustedes comentar según el perfil que estén manejando, ya sea si están trabajando para una compañía o están trabajando para un hospital. A final de cuentas es parte de lo mismo. So, going a little in depth about the needs. So usually you have a process that talks about interviews with the main stakeholders, right? You interview the stakeholders to approach them and just ask them about what are their expectations regarding maybe a project or an operation that you do as a clinical engineer. But also, normally you would put maybe some metrics or some control points to see how well are you doing in certain, let's say, stages of this project. So would that be an accurate measure?
Sure. Yeah, very good. And I'll go into a bit more detail about that as we proceed. Yes, feedback from personnel, and I see some of the chat responses here.
Oh, great.
So let me just talk a bit about that. So using metrics is really what this webinar is all about. So you need to understand what is a metric. Can also be called a performance indicator. It's a measurement of some variable that provides information on how well you're doing your job. The documentation and reporting on metrics is essential components of a quality program. So it's not enough just to make these measurements. You have to be able to report them to your customers and stakeholders. Otherwise, they're not really of much value. But a caution here, there's a risk of trying to measure and report on things over which you don't have full control. And if you're reporting on something that you don't have control over, you're not really going to be able to change that metric and show that you've improved your service. So choosing metrics requires a bit of care, but the selection of appropriate metrics is an essential starting point for process improvement. You can organize your metrics into various operational and financial categories, such as productivity. For example, how many work orders did you close in your CMMS in the past month? That might be a measure of productivity. People issues, how many days of absenteeism have you had in the past month? Is there something you could do to reduce that? That's a people measure. Safety measures, how many workplace injuries have you had in your service in the past year? That's something you can measure, and maybe you could do something to make improvements. Assets, your capital assets are important things that you can monitor in your CMMS and provide various reports to administration on the state of repair of various assets and how many are out of service, those kinds of things. So assets are one of the key things that clinical engineers can provide useful, unbiased information on to senior management. And we'll talk a bit more about that. So as people have intimated, when you're determining your performance measures or your metrics, it's most helpful to first find out what's important to your customers. And then once we know what's important to your customers, make some choices about what it is that you can measure and what it is that you could count, specifically using data from your CMMS, which is the best source of data you'll have. And I guess that's another question. How many of the people in the participants are currently using a CMMS? Can we have a bit of feedback there on, are you currently using a CMMS in your clinical engineering service?
Por acá pregunta, veo que cuántas personas de las que están Por acá presentes están utilizando un CMMS. Is there something you want to know about the use of the CMMS, or just if they're using or not?
At this point, just if they have one that they are using, yes.
Okay. So, lo que quiere saber es solamente si están utilizando un CMMS o no. Some of the people here are using the CMMS that I was talking to you about.
Sure.
I'm well aware that some other people here in the room actually are using some others. I would say maybe half of the people here in the room are using a CMMS.
Okay, fair enough. So, and just for those who aren't, a CMMS stands for Computerized Maintenance Management System, and it's really an essential tool for a clinical engineering service to manage their operations. So, and just an example of a metric that your CMMS can provide for you is repair turnaround time, which would be defined as the time between when a repair work order is opened until the repaired item is back in service. Now, there's a pitfall in getting your CMMS to report on repair turnaround times, because a common practice among people involved in repairing equipment is they get an urgent call from some clinical unit. Their infusion pump isn't working. They need it fixed right away. You run upstairs, you figure out what's wrong. Maybe it's just a switch in the wrong position or some operator error. Anyway, you get the thing working, or maybe it needs a repair. Maybe it needs a part. You may or may not have the part in stock. So it could take you a week before you've completed the repair. There's a common practice of doing all the work, completing the repair, returning the device to the user so they can get it back in service, and then sitting down at the desk and doing the paperwork, opening the work order, documenting the work, closing the work order. And in that case, the difference or the repair turnaround time looks like it's only 5 minutes when it might have been 2 weeks. So there's a danger of the CMMS giving you inaccurate or deceptive data, which would distort the analysis of your results and give you an incorrect picture of what your average turnaround time is for repairs. So you need to use some sophistication to filter some of the data to eliminate things that are obviously erroneous. So just to emphasize that point, you need to choose your metrics carefully, test them to verify that they're accurately reflecting what it is you're trying to measure or change. Keep talking to your customers and understanding what's important to them. Also, get your staff involved in the clinical engineering service. Get all the members of the staff involved in discussions that lead to the choice of a metric. This is going to make it more likely that they will buy into the project and help make sure that the data that the CMMS is generating is accurate. So you really need to make sure that your staff have bought into any quality improvement project that you're going to work on, because they're a key to actually making any of the changes that you decide to do. Okay. Talk a bit about senior administrators and what kinds of metrics that they are looking at, some of which you may be able to help them improve those metrics with some of the data that you can generate out of your CMMS. So just looking at them very quickly, budget shortfall is a huge one. There's never enough money. Are we going to be able to meet payroll this week? We have all these requests for new equipment from the doctors. How are we going to be able to decide what equipment we can buy with the limited funds we have available? Length of stay. What are the delays that keep patients in hospitals longer than necessary? What could we do to shorten length of stay? Post-op infection rates, causing patients to stay in hospitals longer and also perhaps causing injury to patients. Medication errors also can harm the patients. What are the causes of those medication errors? How could we reduce them? These are the things that just some examples of things that senior administrators are worrying about every day. Just to go into that in a bit more depth, one of the tools that they use, because they have so many conflicting issues they have to deal with, one tool they often use is called a balanced scorecard. It's a set of measures that's derived from the strategies and overall vision of the organization. So it centers around 4 distinct measures: customer issues, internal processes, financial issues, and learning or growth. So just to go into a bit more detail on that, customer and patient issues may be inpatient satisfaction, outpatient satisfaction, central line infections, which can increase length of stay, medication errors, post-op infections. So the CEO would be considering his customers to be the patient. And these are the most important patient for the CEO. Stakeholders may be the doctors and the nurses and other staff in the hospital. But the direct patient for the CEO would be the direct customer would be the patient. Internal processes, number 2, might be measurements of average length of stay, adverse events, just 2 examples. Financial issues, days of cash on hand, capital equipment funds, learning and growth issues, employee turnover, employee satisfaction, training and learning opportunities, absenteeism rates. These are all related to learning about the organization. So the balanced scorecard that the CEO has on the screen of his computer might look like this. It's centered on the vision and strategy of the hospital, and it's called a balanced scorecard because each of these 4 quadrants have equal importance as far as the CEO is concerned. And so he has to juggle these 4 balls and keep them all in the air at the same time. And this is just a tool that helps him focus on the important issues that he has to deal with on a day-to-day basis. So how can we relate this balanced scorecard to clinical engineering? This is your challenge. You have a challenge where you need to learn what it is your senior management is measuring and what are they worrying about. Then you need to think about what you could do to improve one or more of those measures. And there are things that you can do, and we're going to talk about that, but let me just give you one example. So medication errors are of great concern because they're one of the most common causes of injury to patients in a hospital. Medication errors can be caused by a wide variety of factors, but in a clinical engineering service, you're looking after some of the equipment that may be implicated in a medication error. Can we get some feedback? Do you have some idea of what that equipment might be that could be implicated in a medication error?
Por acá se pregunta cuáles son los equipos que posiblemente puedan estar involucrados en un error para suministrar medicamento. Por acá, right, so infusion pumps, IV pumps, vaporizers. Great. Okay.
Great. Okay, excellent. Thank you. Yes, that was an easy question. I'm glad we got some answers there. So I'm just going to look at the infusion pump. It's a golden opportunity for medication errors. There have been a number of human factors studies of the way nurses interact with infusion pumps. And one of the big Toronto hospitals has a human factors group that has, I've watched some of the videos they've taken of nurses trying to enter infusion rate and medication dose into an infusion pump. And the number of errors they make in entering those 2 variables is frankly quite frightening. And the infusion pump is something that the clinical engineering department is intimately involved in looking after, maintaining, and making sure it's operating safely and reliably. So there's an opportunity for clinical engineers to have an impact on medication errors by studying the way nurses are using the pumps and the way they're making errors in the use of those pumps. I'll just talk about one other example before we move on to some of the things related to CMMS. Capital equipment budgeting is a big problem for CEOs because there are always more demands to purchase new equipment than they have funds available. You as clinical engineers with a CMMS have the best inventory of capital assets in the organization. Your finance department may keep a capital asset register, but it's typically out of date and inaccurate. And the people in the finance department who are given the responsibility of maintaining the asset register really don't understand most of the items of medical equipment that they're trying to put in their inventory. You have the best inventory because you understand the medical devices that you're looking after. So you can report on all kinds of parameters related to the capital asset inventory. You can report on the number of items that are out of service but repairable. Maybe they're not being repaired because you don't have the budget to buy the parts, or you haven't been on the necessary training course to learn how to service that equipment. But these are important parameters. You can report on the diversity of brands of infusion pump, for example. If your nurses are having to operate 3 or 4 different makes of infusion pumps, each one is going to have a different way of entering infusion rates and medication dose. And when they have to switch from one pump to another, they're going to have to switch from one method of data entry to another. Again, it's a golden opportunity for error. So reporting on diversity of brands is a measure of the potential for errors. You can also report on the age of the equipment in your inventory, which will help the CEO to prioritize when he's got competing demands for the new equipment. The oldest and least reliable equipment, obviously, as measured through your CMMS data, gives him at least an unbiased measure that he can use to help make his decisions. So just in summary, talking about what the CEO is worrying about, you need to understand those metrics, and they'll be different in every hospital. Understand what metrics your senior administrators are concerned about, and find one or more of those metrics that relate to the clinical engineering service that you are providing. Then you can use that information to develop your own metric that you can report back to senior administration and help them do their job better and improve the quality of patient services in the organization. So I'm going to take a different tangent here and talk about a tool that we use in Canada to raise our profile with senior administration. The first thing we did was develop what's called this Clinical Engineering Standards of Practice for Canada. It's basically a best practice guideline, an operational guideline for clinical engineering units in Canada. Not all of what we have developed would apply to your country or your healthcare system, but I just want to give you a flavor of what we've done and how we're using it to raise our profile. So the purpose of this was to define the scope and role of clinical engineering in Canadian healthcare organizations. We wanted to define standards that were suitable for measurement and suitable for peer review. And I'm going to talk about our peer review process. But again, each of our elements of our standard of practice is an element that can be measured to measure how well you're meeting that particular standard. And we use that in our peer review process. We were dissatisfied with Accreditation Canada's understanding of clinical engineering in Canadian hospitals. We thought they were giving a very superficial assessment of clinical engineering services, and that's why we developed our own standards of practice and implemented our own peer review a process which kind of mimics an accreditation process, but is specifically focused on the services of a clinical engineering department. And so to talk about that in a little more detail, these are the sections in our standards of practice. These are modeled after an ISO standard. We use the ISO guidelines for developing standards in the hope that perhaps someday we can get this registered as an ISO standard, although it's specifically developed for Canada. So the first 5 sections really are based on ISO requirements, that you need to have a forward introduction, statement of the scope of your standard, and then references that you've used to develop the standard. But the most important sections are 6 and 7, which I'll talk about in just a little more detail. Section 6 talks about how you manage the clinical engineering service. Section 7 talks about how you deliver your services or service provision. So section 6 talks about management responsibilities, documentation requirements, resources management, service realization, how you deliver your service to your customers, management analysis and improvement. So an important component that we think all clinical engineering services should be involved in is an analysis and quality improvement program. So management analysis is part of effective management of a clinical engineering service. And section 7 talks about how do you provide that service to your customers. You should be involved in technology assessment. What are the new healthcare technologies coming down the stream? You should be, or you may or may not be involved in research. You're probably involved in the modification of devices to meet user needs. You should be involved in site and facility planning, because there's always equipment involved in facility planning. So you should be involved in equipment planning. Procurement of new equipment, you should have a good relationship with your purchasing department. So when they're procuring some piece of complex equipment, you know about it, and you make sure that they include training and spare parts in that procurement. If you're not talking to your purchasing people, you may end up without some of those essential items. And commissioning of new equipment when it arrives in the hospital to make sure it can work the way it's supposed to. You should be involved in commissioning new equipment. A couple more: user training, education, and teaching. You may not do direct teaching, but you might be assisting in the teaching of your equipment users. And of course, device maintenance. Are you doing preventive maintenance? What kind of a preventive maintenance program do you have, and how do you deal with repairs? You should be involved in risk management, dealing with incidents of patient injury in the hospital that have to do with equipment, and clinical data and system management. More and more clinical equipment is being connected to the IT networks in the hospital, and so there's an important role for clinical engineers to talk to the IT department and interact with them related to connecting the clinical diagnostic equipment to their IT systems. And finally, disposal or relocation of equipment. You should be involved in decommissioning, disposal, and relocation of hospital equipment so that it's properly taken off the inventory and removed from service. So again, just to talk briefly about how we use those standards of practice in a peer review process. So peer review process involves, first of all, it's a voluntary process. A clinical engineering service has to request a peer review from the society. Then the society has a committee that looks at the application to request a peer review. We put together a team of 3 or 4 clinical engineers from outside hospitals who are not working in your hospital. And we arrange for them to come and assess your service and measure how well it is meeting the standards of practice. Now, the question that everyone raises is, why on earth would you want to subject your service to a peer review? It sounds like it's going to be painful. So I'll try and answer that question. First of all, you don't need to be meeting all the elements of our standards of practice to have a peer review. This is just one of the departments we've reviewed and some of their staff. In fact, the greatest benefit will be realized by a service that's just partway along the road to meeting the standards of practice. If you're just partway along the road to meeting the standards of practice, you've been doing some improvements, you're working on improving your service, but you really don't think you're there yet, we can then help you prioritize what things you should be putting your energy into. Now, the other advantage of a peer review is that by meeting with your stakeholders, your customers, and with senior administration, the surveyors in the peer review will help to raise your profile in the organization. So we'll meet with nursing managers, doctors, senior administrators. In a recent peer review that I was a surveyor for, we had a half-an-hour meeting with the CEO of the hospital, and it was probably the longest time she'd spent thinking about clinical engineering in the past year. But we were asking her all kinds of questions about her clinical engineering service and whether she thought they were doing an effective job. So again, to answer this question, why would you do this? Outside peers looking at your processes can be of great benefit in helping you to prioritize your next steps in a path to improving your service. And I'll just give you an example. A peer review that we conducted for a hospital in 2015 contained recommendations that the clinical engineering department needed a larger workshop and more test equipment. They were poorly equipped, they were working in a very cramped space, they were having a lot of trouble delivering their service because they were tripping over each other and they didn't have all the right test equipment. We then repeated the peer review 4 years later in 2019. In the follow-up peer review, we found that they had been successful in having these needs met because they had outside experts coming in and telling in their written report, which everyone could read, that they really didn't have enough space and they didn't have enough test equipment. Senior administration actually paid attention and got them some more space and got them some more test equipment. So that's just one example of how our peer review process has raised profile of clinical engineering departments in Canada. So just some examples of questions we ask of customers of the service, just to give you a flavor of how this works. We'll ask the customer, how responsive is the service when you need them to help you out? Do they visit your area on a regular basis? What about after hours? Do you know how to get service after hours from them? And how does that work? Are they involved in capital planning or replacement forecasting for your equipment? And are they involved in incident investigations? Those are just a few of the questions we will ask in a meeting with customers. And we'll typically meet with half a dozen different customers. And we'll try and meet with 2 or 3 senior managers as well and ask them a different set of questions. Just some samples of things we'll ask senior management. What information do you get on productivity and cost effectiveness of your clinical engineering service? Who reviews and approves the current budget for the clinical engineering department? And what is the role of clinical engineering in the organization's risk management program? So again, we're asking this. In the picture, this guy was the director of plant operations and maintenance, and he had the clinical engineering service reporting to him. So we were asking him these questions about his service, and again, forcing him to think about the kind of service he was getting from clinical engineering and the kind of information they were providing him. So in summary, just to close off this section, why would anyone want to subject themselves to a peer review? 2 answers: raises your profile with your customers and with senior administration. And it stimulates discussion within your department about what your priorities are and whether you're meeting current best practices. So that's just, I wanted to introduce that to give you something to think about kind of as a long-term goal, perhaps, to develop your own best practice guidelines for your health system. And just to emphasize that point, you need to develop your own guidelines. Each country has a unique healthcare system and a unique set of issues that they're trying to deal with in their clinical engineering service. So countries like Australia, France, Germany, Canada have developed their own best practice guidelines, or standards of practice as we call them. But you could only use those as a template, but you really need to develop your own guidelines that meet the needs of your health system. So I'm going to talk now about ways to understand customer and stakeholder needs as part of a quality process. So as we discussed before, a customer is anyone who you provide service to. And examples are nursing managers of clinical units, physicians, respiratory therapists, for example, other people providing clinical services to patients using equipment that you look after. And a stakeholder then is anyone who has an interest in the effectiveness of your activities, someone who's going to look bad if you're not doing a good job. An example is the administrator that you report to. So first of all, you need to understand who your customers and stakeholders are as the foundation of your quality improvement activities. So ways to understand customer needs, we've talked about this briefly, but customer surveys is one tool that you can use. Create a simple survey, no more than 5 to 10 questions that could be completed in 10 minutes or less. An example of a question you might ask is, name one way we could provide you with better service. When you're giving this questionnaire out to your customers, they're going to be reluctant to spend time answering the questionnaire. It's like pulling teeth some ways, sometimes to get people to answer questionnaires or surveys. So an effective method we found is to offer incentives, especially to nurses. Nurses will always come to a meeting where there's food. We set aside a meeting room near where the nurses have lunch. We brought snacks into the meeting room and offered to provide the nurses with snacks if they would spend 10 minutes filling out our survey questionnaire. And we got lots of responses because we'd offered an incentive. If you just email out a questionnaire, you're going to get a very low response rate, typically only from people who are dissatisfied with your service. You want to hear from a broader range of your customers. And so you need to think of ways to increase the response rate for your surveys. I'm just giving you one example of how we did that. Another way you can understand customer needs is invite them to one of your department meetings. Invite a nursing manager or a physician and discuss common concerns relating to equipment. For example, a common issue we learn about in doing our peer reviews is, what is the process for ordering and paying for repair parts? Could we streamline this process? Is there a lot of paperwork involved? Is there some way we could reduce the amount of paperwork before the clinical engineers get the part they need to do the repair that needs to be done? Is there information that we in the clinical engineering service could provide you that would be useful to you, such as a list of the equipment inventory that we think is assigned to your department that we think that you own? You may be surprised that the customers sometimes see things on the inventory list that we thought belonged to them, and they think they haven't seen it in months, and it's somehow wandered off to some other nursing unit and never come back. So an inventory is a very helpful document for a nurse or a physician who's running a clinical service and isn't really sure how much equipment they have. You have that data in your CMMS. So again, the question, why is it important to understand customer needs? This points you towards metrics that will help you to improve your service. So we'll talk about that using a typical tool that's often used in quality improvement to to implement rapid improvements and test out any changes you make to improve your service. So it's called a PDSA cycle because there are 4 steps in the cycle: plan, do, study, and act. Plan means plan the change that you think you want to test or implement to make some improvement. Do is carry out the test or the change. Study then, collect data before and after you've made some change, and reflect on that data. Reflect on what was learned when you look at that data. Has the change you made caused an improvement, or has it been ineffective? Then the final stage is to act. You can either decide to implement that change as a permanent practice, or you can abandon it and plan the next change cycle to try something different. So this is a very rapid quality improvement tool that is widely used. And I'll just go through some examples here. For example, you have a meeting with a nursing manager or doctor who says, sometimes it seems to take forever to get something repaired, and I don't know why it's taking so long. And I don't know when I'll get my equipment back. This is a common complaint from nursing departments. So this is part of the planning stage of developing an improvement in one of your processes. So you start by listening to your customers, understanding their needs. They need to know why equipment is taking so long to repair. Then the next thing you can do is plan and use the CMMS to generate a weekly report on work orders that have been open for more than, say, 2 weeks. The number that the CMMS gives you on these work orders is called a metric. So now you've taken an action to generate some data that gives you a metric that tells you about the work orders that have taken a long time to close. Then in the next stage of the PDSA cycle, you study that data. Every Monday, for example, you might have a brief staff meeting to discuss these long overdue work orders and brainstorm ways to reduce the number. An example might be you learn you don't have a process. If somebody goes away on holiday or calls in sick, you don't have a process to deal with their outstanding work. Maybe they've done a repair and they're just about to put the covers back on the equipment and take it back to the nursing unit, but it's Friday afternoon. They figure they'll finish that on Monday. Monday they call in sick and they say, I've come down with a bad case of the flu. I'm going to be off for the next week. So the repair turnaround time could now take an extra week simply because somebody's called in sick. So you need to have a process to look at the work that has been not completed but is outstanding for someone who's away, who's just gone on holidays or just called in sick. Maybe there's an important repair. It just needs the cover screwed back on and taken back to the nursing unit. Someone else can be delegated to do that task. If it's an important repair, you should be handing it off to somebody else. Your CMMS can give you data that tells you which repairs are long overdue and which repairs are under the responsibility of someone who's just gone off sick or just gone off on vacation. So again, one of the steps to help your customers understand the reasons for long work orders is to implement a practice of routinely updating customers on the reasons for long delays in equipment repairs. That is a very simple activity that takes almost no time, but will relieve a great deal of anxiety and dissatisfaction on the part of your customers. And the data in your CMMS will help you implement that practice. So again, I've just talked about this. I got a bit ahead of myself, but this again is a PDSA cycle. I talked about if someone is sick or off on vacation, you need to think about a practice of handing off high priority jobs to another staff member. You can implement this change and record the metric over several months. The metric being long overdue work orders that have been open for more than 2 weeks. Now you're going to look at a time change in that metric over a period of several months. Just keep recording the data and looking at it week after week and seeing if it's changing. After several months, look at trends in that metric and decide whether or not it has improved, or maybe there hasn't been a change and so the action you took was ineffective. But at least you can't know that unless you've actually taken a measurement and made an observation and studied those measurements. So that's the way your CMMS can generate metrics which will help you improve the satisfaction of your customers. If it does improve the turnaround time, then you can make that change a permanent practice. So you're going to have weekly Monday morning meetings where you look at the long overdue work orders and decide what action you can take to close some of those work orders. You won't be able to close all of them. You may only be able to close 1 or 2, but it'll still improve that metric and improve the satisfaction of your customers. Okay, I'm going to open it now for Q&A just to give you a summary of what I've been talking about in the past 55 minutes or so. We had an introduction and people told me about where they're working and I told them about where I've been working, talked about basic quality concepts. What is a metric? What metrics do senior administrators look at? I talked about our clinical engineering standards of practice and our peer review process and how we use that to raise our profile with senior administration. I talked about ways to understand customer and stakeholder needs, talked about developing metrics from customer feedback, using the PDSA rapid improvement cycle, and using data from your CMMS. And now we're at item 7 on our presentation, which is the Q&A. I want to open it for group questions, people to start some discussion about what you think you might be able to do using the information I've been presenting to you today.
This information was, was a lot of information. It was a really, really good information on that can really help Latin American clinical engineers as myself to understand better what works and what doesn't. I would like to ask a personal question. We've talked about a little bit about the profile in Latin American healthcare organizations. So since there is not many management education to clinical engineering in the university process, as well as in the hospital and in the business world, etc. So there's little culture of producing quality metrics or even understanding what a metric's value is. So if you would say, well, actually my question is, if I were to ask you, all right, so for basic clinical engineering metric generation, what would be your top 5 metrics that would generate the most impact if the clinical engineering is just starting to pursue a career in the management headset or vision of clinical engineering?
Okay. Yeah, thanks. Great question, Luis. I'll try and answer that. And these are just things that come off the top of my head. But I did talk about your repair turnaround time. That's really something that can give you insight into your work processes. What is it that, if you've got repairs that are taking weeks or months to complete, some of that's beyond your control. It may take 6 months to get a part from Germany or wherever, and you can't control that. But there are other things within the workplace that you can control. So turnaround time is a really useful one to help you improve things that your customers will appreciate. A second one that we did a small quality improvement project where we got some data out of our CMMS on work orders where we were called to do a repair and there was no fault found. And we could code that work order as a no fault found work order in the CMMS that we were using. Now that, again, relies on your CMMS having a code that you can enter when someone asks you to fix something and there's nothing wrong with it. That's a very important and a frequent cause of service calls to clinical engineering. They call you, you go up, you look over the equipment, and either they push the wrong button or there's something they didn't understand about how to use the equipment effectively. So no fault found work orders. And I'll give you an example of the no fault found project that we implemented. We had looked at no fault found work orders, and we found one particular nursing unit was having a lot of no fault found work orders around patient monitoring cables. So the patient monitoring cable, you know, they stick ECG electrodes on the patient's chest and plug it into the cardiac monitor. And then if they're getting a lot of noise on the screen, they throw away the cable, get another one and plug it in, and then they seem to be getting a better signal. A common problem we have in Canada is in winter, the air is very dry. When skin is dry, skin impedance goes up, and nurses were not doing proper skin prep in this particular nursing unit before they applied the ECG electrodes. And so we identified, because we had a lot of no fault found work orders from this particular nursing unit related to patient cables, we realized that they needed more training on how to prepare a patient's skin before they applied the electrodes. So we gave them a couple of training tutorials on skin prep, and the no fault found work orders from that nursing unit dropped. So that's, anyway, a bit of a long-winded answer. Talk about another one, the metric of your capital equipment inventory. There are several metrics you can use in the inventory. Equipment that is out of service but repairable. Equipment that is one metric. So a list of equipment that is out of service but repairable. And some of it you may not be able to repair because you don't have the parts, you don't have the tools, you don't have the training. But the hospital doesn't have the money to hire the outside service company that would be the only person who would be able to repair that equipment. If you can generate a metric showing how much equipment is in this category, you may have a strong argument to go on some training courses, to get some new test equipment. You could save your hospital a lot of money in repair costs if you can do the repairs in-house. So there are lots of metrics you can generate from your capital equipment inventory. And one of them is equipment that's out of service but repairable. Another metric that's most useful to senior administration is the age of the equipment in your inventory. Where is the oldest equipment? Where is the equipment that is causing the most frequent repairs? That is the equipment that is the most unreliable. That's, again, data you can get out of your CMMS that will help senior administration make decisions about prioritizing new capital equipment acquisition. That's 4, but I think I've been kind of long-winded, so I'm going to stop there. Anyway, I've run out of ideas. Over to you, Louis.
Thank you, Bill. Thank you, Bill. Actually, you know, we've discussed about the statuses, the functionality statuses of equipment regarding CMMS implementation, which is always a good, you know, good point of view, and it's nice to hear that it's working as well in Canada and might work for us in Latin America as well. I would like to ask any of the people that are here with us, which are very professionals in the clinical engineering area. So if you have any questions you might want to ask to Bill, please go ahead. Bill is the chairman of the Ontario Clinical Engineering Society, and he has a lot of experience, and it was I can't say it wasn't hard to get him here with you tonight. So if you want to go ahead and ask Bill a question, that would be great. Or maybe just make a comment or ask for a tip or something.
While you're thinking this, I always put this picture up at the end of my presentations. That's my grandson, Leo.
Oh, great.
Caught him in a very quizzical pose.
Nice. All right, so here we have a question from Enrique Poncio. At what point should engineers stop overseeing facility planning and things such as IT? when it no longer concerns medical devices.
Oh, this is interesting. So I think Enrique is saying that he is currently responsible for overseeing facilities planning, that he is,
Yes, so.
that's a tough one because you're going to have to get the hospital to hire somebody else, right? Is this, I'm not sure I quite understand the question, but it is, there are many clinical engineers who have in fact migrated up to senior positions running IT departments, running planning departments. I know of one clinical engineer who actually became the CEO of a hospital. So the sky really is the limit if you can get your foot in the door and get people to appreciate the knowledge that you have and how much value you have. Engineers have a very different way of thinking than clinical people like doctors and nurses. Our education leads us to think in terms of systems and processes in a very rational manner that clinical people often don't, aren't comfortable with. So I'm not sure I'm going to advise you to offload those responsibilities. Maybe you just need to get more staff in your clinical engineering service to deal with those as those responsibilities expand. Sorry, I don't have a better answer for that, but I think you're in a unique situation there.
No worries. Here he is complementing the question here. For example, a supervising maintenance department applying new coats of paint to the walls, supposed to be something that can't be asked of me.
Absolutely not. I totally agree. You're wasting your time and your education doing things like that. The challenge is to persuade the people who can make the decisions that you need a supervisor to run the operation of your painting staff. You need a supervisor who's dedicated to that and perhaps other relatively straightforward tasks so that you can use your skills to greater benefit for the organization. And so part of that is showing them how valuable your skills are by using some of the examples we talked about here. So make sure they understand that your skills are too valuable to be used supervising someone who's applying a coat of paint. That's the best I can do with that.
Excellent. So mainly you can use the metrics, or some of the metrics provided by Bill, or maybe in some other, research paper or something to just prove that the use of the time in the activities that you mentioned is not feasible for the organization in general. All right, great. All right, so anybody else has a question? ¿Alguien más tiene alguna pregunta? Yo con muchísimo gusto puedo traducirla al inglés si así lo prefieren. Bill es una persona con mucha experiencia que por lo regular está ahora sí que muy, muy ocupado. Y pues bueno, sería interesante que si tienen alguna consulta la pudieran hacer. All right, so Stephanie asks, if we were talking about maintenance tasks, do we have to be interested about those which could affect our medical devices? All right, so Stephanie, lo que estás quisiendo preguntar es relacionado a temas de mantenimiento, o sea, que no son propiamente de biomédica, sino de infraestructura, conservación y demás. La pregunta es si deben de estar ustedes al pendiente de aquellos que potencialmente pueden afectar al dispositivo médico. Okay, so what Stephanie is asking is regarding like other activities, for example, infrastructure or maybe industrial maintenance, of the facilities or something like that. So should the clinical engineers be aware or maybe on the watch of those which could be harmly potential to medical devices? Like not, but maybe just like, I don't know, power outlets or maybe air outlets or stuff like that.
Yeah, absolutely. But you need to make sure there's a clear boundary being drawn between what your responsibilities are, and the maintenance department, and facilities maintenance. You need to be actually developing good relations with facilities maintenance because as we found, I'll give you a couple of examples. In the hospital I worked in, we would often find, because things like hospital beds get pushed around and banged into electrical outlets, we would find damaged outlets in a nursing unit that, they had exposed wires or they were lacking ground connection or whatever. We would put a big red sticker on that outlet saying, defective, do not use. Then we would phone up the plant maintenance department and say, we've just taken an electrical outlet out of service because it's not safe to use, but they really need it because they don't have enough outlets to operate their equipment. So could you please repair that outlet as soon as possible? So we basically identify a need, but hand it off to the people. I'll give you another example. Most hospitals have some kind of standby power for when the mains power from your power utility fails. It happens more in low resource countries than in Canada, but we still get power failures. I know the hospital that I worked in once, we had 2 different power feeders coming to our hospital from different directions, but once we had a severe ice storm, both of them failed. The diesel generators kicked in and started supplying power to essential services. But the problem with the power switchover from power supplied by the utility to power supplied by the generators, there's typically a 5 to 10 second blackout, and then emergency power comes on. That blackout can cause havoc with sensitive, especially computerized equipment. So we had to work with the plant operations department to figure out which outlets were being provided with emergency power, which weren't. Sometimes we had to provide a UPS to, if the equipment was too sensitive to the gap in power when there was a switchover. Also, the plant operations department would routinely test their emergency generators once a week. And during that test, there was a power switchover, which again caused havoc with some of the equipment. So we had to do a lot of discussion, interaction with plant maintenance to minimize the impact of the work they were doing to make sure that they were able to provide emergency power. So those are just a couple of examples. You need to have good relationships with the other departments that are looking after the infrastructure, because you're often the ones who identify problems with the infrastructure, but you shouldn't be accepting responsibility to do the repairs on that infrastructure, because there are other people who have the training and the skills that are not at the same level as your training and skills. You shouldn't be repairing electrical outlets. Kind of a long-winded answer. I hope I've answered your question. Thanks.
Yes, you did. All right, Bill. So we're 14 minutes past your time. So we'd like to thank you very, very much. The time that you dedicate to us tonight. I know it's late over there as well as here. And we just want to let you know that we would be happy to have you anytime you'd like here to just learn about your experience about peer reviews. Actually, for the people that are listening to us, the peer review in Canada is a big thing. They have done an amazing job. So I've been told by Tom Judd and some other people. And well, thank you very much, Bill. It has been a pleasure. Of course, we'll see you soon. And well, I don't know if you have an additional comment or a question you'd like to answer, or what you like to be, a question you'd like to ask.
Well, I guess, yes, there are 2 things, and this is an oversight. I meant to put on my final slide my email address. So maybe I'll ask Lewis to circulate my email address
Sure.
to the participants. But in addition, I would encourage you to take a look at our Tools for Text project. Actually, I could type this in, couldn't I? Yeah. Why don't I do that?
In the chat you can.
Yeah. Here's my email address. And I'll also give you the website of our Tools for Text project. I encourage you to take a look at it, see if you qualify, send in an application form. We'll tell you if you meet our requirements, and then we'll ask you to shoot a minute or so of video telling us a story about where you work and stuff. So those are a couple of things I thought I should mention. But again, Louis, I appreciate and grateful for you inviting me to participate in this. I'm glad I could find the time to come and participate in the webinar and meet some of the people who you're working with. And it was a great pleasure. And thank you very much for your attention.
Thank you so much, Bill. We appreciate your time and wish you a very, very good rest of the year, and as well as the week. So if anybody has some other questions, you can just write to Bill at billgentos@simpatico.ca. And we'll stay tuned for more webinars like this. And well, to everybody that's listening to, we have one more and last webinar that's going to be next week. So I hope you guys enjoy it, and let us know if you guys have additional questions. All right. Thank you very much, everyone. On behalf of the TINC team and myself, we thank you very much and wish you a very good night. Thank you very much, Bill. Good night.
Thank you. Bye-bye.